Hi, it's Dr. Centeno, and today we're going to talk about a topic I presented at the TOBI Conference last month, looking at whether or not the stem cell dose in bone marrow concentrate has something to do with knee osteoarthritis treatment outcomes, meaning is a higher dose of stem cells in the bone marrow we use important, or is it unimportant? Now, in all of medicine, dose is a very critical concept, right? You wouldn't take a medication unless you knew what the dose was. The doctor wouldn't prescribe the medication unless the doctor knew what the dose was. However, in autologous biologics like PRP and bone marrow concentrate, dose is often not measured and not even looked at as a concept, meaning that you take some bone marrow from a patient, you put it in a magic little machine, you take what comes out of the magic little machine and you put that in the knee. And at no time in there does anyone look at the dose. Now we do at Regenexx look at the dose, but that's not what everyone else does. So we know, for example, that PRP dose is critical. So here, this is our study that was published in 2019. And this looked at the PRP dose in patients who were either over or under 50 years of age. Now, this is sort of an arbitrary break point. I can tell you that we would see the same thing in a 35 or 40-year-old, but for the terms of the paper and the research, this is what we saw. So basically, this is PRP dose here, 1x, 2x, 3.5x, 7x, 14x. And for patients who were younger, it didn't really seem to matter. 3.5x is where you got your maximum growth of tendon cells. And so this was a study in the lab trying to see how the dose of PRP would affect tendon cell growth, because PRP is used to treat tendinopathy. But as you got to older patients, you saw this direct dose response relationship. And in this direct dose response relationship, if you inject 3.5x PRP, this is the amount of tendon cell growth you get. But if you go up to 14x, you get more. And like I said, this is an arbitrary break point here of 50 years old. In our experience, this break point is somewhere between 35 and 40 in practical daily usage. But for this study, we chose that break point. So if you base it, so what this shows us, if you get a younger patient, you don't need to go high dose on PRP. But if you've got an older patient, and again, our experience is older than 35 or 40, let's say 40 just to be arbitrary here, then injecting a higher dose of PRP matters. Now, this is a problem because very few doctors who inject PRP know the dose or even care about it. Obviously, we do at Regenexx. We dose patients all the time based on this and other research we've done in the lab, but just out there in the wild, we're not seeing doctors really care about what the dose is. But this study and the others we've done clearly show that it matters, especially if you're older. Now, we published a while back that you could measure total nucleated cell, meaning the number of cells in a bone marrow concentrate injection, and that would link up to outcome for the procedure, meaning the more cells you injected, the better the procedure did. Now, this is total nucleated cells. It's not stem cells. It's just the total cell content of the injection. So since then, we've been dosing our bone marrow concentrate and measuring the dose, the total nucleated cell dose. But regrettably, a few others have been doing that. So 99% of the time when you get one of these procedures, the doctor doesn't know the dose of the total nucleated cells. He doesn't know if he's got enough to help your knee or not enough. enough to do both knees. As you can see, this can become pretty important, right? If you had a lower dose that in your bone marrow concentrate of total cells, you probably wouldn't want to do both knees. That you're going to make it more likely that the procedure is going to fail for that patient. So obviously knowing the dose we figured out a while back is pretty important. That's why we always measure the dose at Regenexx, but few other clinics do. And we know that there are other dosing studies out there. There's one in treating lumbar discs with bone marrow concentrate, and that used the CFU-F, which is what we're going to talk about in this study. And another one in treating bone disease like osteonecrosis. So in those cases, again, the dose mattered. If you had more CFU-Fs, which is a proxy for stem cells, in your bone marrow concentrate, then you got a better outcome than if you had fewer. All makes sense, but again, no one's collecting this data or even looking at these concepts outside of Regenexx and a few other providers. So does the CFU-F matter in treating knee OA with bone marrow concentrate? Bone marrow concentrate, often called a same-day stem cell procedure. So if you've got a patient who has more stem cells in their bone marrow concentrate, are they more likely to do well versus a patient with fewer stem cells in their bone marrow concentrate? So what's a CFU-F? That's a colony forming unit fibroblast assay. We plate the bone marrow concentrate in culture and wait for colonies to form. And this is what it looks like up here. These dots are a colony, and each colony represents a stem cell that started that colony. So the more little dots you have, the higher CFU-F number. The higher CFU-F number, the more stem cells are in the sample. Now, there are positives and negatives of measuring CFU-F. From a positive standpoint, I just showed you research looking at the stem cell dose in bone marrow concentrate. So it seems to be a thing, but no one has tested it in knee osteoarthritis, but in other applications, we know that the total cells matters as well. That's our research. Now, the negative for this measurement is you can't use it in real time to impact treatment decisions. And this is a big one here because obviously the doctor needs some metric that he or she can use in real time that says this person's got a low dose, this person's got a high dose. And you can't do that with CFU-F. You've got to grow this out in a lab for about a week or 10 days. So you can't really determine it in real time. And another thing to consider is that these figures of CFU-F vary wildly between different labs. So this only really works with one lab looking at whether or not it's a high dose or low dose sample. You can't compare a low dose CFU-F number to a high dose one found in the same lab because that may be the same exact bone marrow. What I mean by that is that it's counted differently, there are different plating techniques, so this isn't a number that generalizes and can be compared from one lab to another, but it can be compared within that one lab's work. And another problem was it was possible to use this after the fact for research purposes until our recent paper. And our paper really changed that. We published that not too long ago. So this is our recent paper using cryopreserved bone marrow concentrate to look at retrospective CFU-F counts. So this is the first time anyone has tried to figure out, and this was done by our research group here at Regenexx, this is the first time anyone has tried to figure out how you can use this after the fact. And what I mean by that is we now, for instance, at our Colorado HQ site, we save a sample of bone marrow concentrate and cryopreservation for every treated patient. And for research purposes, we can now go back after the fact and plate that and determine the CFU-F numbers. Prior to this publication of this paper, there was no way to go backwards and try to determine if there was any CFU-F number. So We changed that. We allow that can be done now because of this paper we published. So again, this is a critical finding that we found in this paper, and the translation metric that we published, because instead of having to plate bone marrow concentrate that same day, you can now cryopreserve it and then use our published data to run a retro CFU-F and make the translation from frozen to fresh. So you don't have to run it the same day anymore. And that's really important because at the end of the day, if you had to run CFU-Fs all the time fresh, it's one of the reasons why it never gets done. It's exhausting. You'd have to have someone full-time in the lab who did nothing but that. Now with our paper, you can plate these 2 years later and plate 50 of them at a time. And so it's much more efficient way from a research standpoint to get this data. So these are the study demographics here. We had 22 patients that were non-responders. We had 43 responders, male, female, etc. This gives you all of the information that we're looking at. So we found that for our lab, that there was this cutoff dose. And again, this only applies to the data coming out of our lab. You can't compare CFU-F numbers from one lab to another. But we found this cutoff dose of 18,000 CFU-F for responders versus non-responders. So there seemed to be a minimum dose of stem cells in the sample that was important for outcome. And this is pretty important information here, and it's a little bit hard to look at, but this is what's called a gun plot. And so what we're looking for is that if we have more dots that stay out of this red zone here, and that cluster in this gun-like shape, right, that almost looks like a gun there, then there is an association between better functional improvement or percentage improvement and the number of CFU-Fs. And all this really is looking at is if you have more CFU-Fs, do those dots cluster up here? And the answer is they do. So there is a nice association between the number of stem cells in the sample and the actual outcome of the patient, meaning those patients who had more stem cells in their sample were more likely to report getting better from a bone marrow concentrate for treatment for knee osteoarthritis than those who had fewer. So in conclusion, like low back discs and osteonecrosis, knee OA treatment is also CFU-F dependent. So again, the more stem cells you have in the sample, the more likely the patient is to respond. And this begs a really big issue, right? If this is true, then there's a key fact that's being missed in bone marrow treatment. So I'm going to say that one again because it's so critically important. If the amount of stem cells in the sample for a same-day stem cell type procedure, or otherwise called bone marrow concentrate, is important, then the amount of concentration that you can achieve as the doctor who's doing this procedure becomes also critically important. That means that if you've got a system that can concentrate bone marrow more than another system, that's critical because you're going to have more patients who report more positive outcomes if you concentrate the bone marrow more. But the problem is that most doctors have no clue how concentrated the bone marrow is or isn't that they're injecting. They're not measuring that concentration. Now we do it at Regenexx, but that's not how it's done 99% of the times. We do it based on our old paper that shows that the number of total cells in the injection mattered. And obviously this new data now shows the number of stem cells matters. So again, being able to concentrate those stem cells is critical, because if you have a poor ability to concentrate those cells, then you're going to have more patients that fail this procedure. So again, this is a critical finding that I can't emphasize enough. Number one, having a machine that can concentrate, or a system that can concentrate the stem cells, is critical. And you want the machine that can, or the system that can concentrate them the absolute most. And number two is knowing what that concentration is by measuring total nucleated cells. So you have some idea that you're doing your best work at concentrating this stuff, or that you know that you've got a low concentration sample, and you can't do something like treat someone's bilateral knees without increasing the failure rate for that treatment. Those are critical things to understand. So what does this research all mean? From a 30,000 foot view, we need to find a way to get this type of stem cell concentration data before we inject the patient, so we know what that stem cell dose is. Flow cytometry could work. We're exploring that right now in our lab using a CD271 marker. But the problem is it takes a PhD level lab person to run a flow cytometry machine. So that while it's practical for our practice, because we have a university equipped lab on site in our Colorado HQ, it's not practical for the average doctor's office. And TNCC, however, likely works. So our older paper showed that looking at the total number of cells in the sample is important for clinical decision making, but no one's doing that. Why aren't they doing it? It's an extra step that you've got to do. You've got to have a lab like we do at our Regenexx sites to be able to pull that off. And most doctors don't want to take the time. They don't want to invest the money, have the employees that can read these things and determine the number of cells in a sample. So they're just taking whatever it is they can get. And the problem is, I fear, is that they're making all sorts of bad treatment decisions. Like, patient comes in and wants bilateral knees done. And they say, sure, happy to do that. But if you look at the total number of cells in the sample, that particular patient should never have had bilateral knees injected, because they're more likely to fail the procedure if they do. Whereas another patient who has a lot of cells in their sample may do fine with treating both knees. So at the end of the day, this is important information. And again, it all comes down to how concentrated is the bone marrow that you're injecting into knees, because that's tied to outcome, like it is tied to the outcome of injecting bones, or like it is tied to the outcome of injecting discs in the low back. Concentration matters when it comes to these procedures.